Hello everyone, I'm doing my YouTube video for our final project regarding clinical outcome assessments in practice. I will start with my clinical case scenario. I present to the class a 26-year-old left-handed professional pitcher at the major league level with less than 2 years of major league service time, complained of left posterior shoulder discomfort, specifically in a teres major and latissimus dorsi insertion after pitching. The athlete is currently on the disabled list after making his second start of the season and still not being able to fully recover due to pain and discomfort with throwing. Upon examination, athlete self-reports a pain scale of 8 out of 10 with throwing and 6 out of 10 with rest. He has limited and painful range of motion, inflection, and abduction past 90 degrees. His manual muscle tests were 3+ out of 5. When tested latissimus dorsi in extension, he was 3 negative out of 5 with pain. No neurological symptoms or signs of latent pathology were present. No prior history of shoulder discomfort. And this athlete was recently converted to a starter this offseason. Diagnostic images were obtained, x-rays were negative, and MRI reports revealed a mild to moderate latissimus dorsi strain. A conservative approach was referred rather than surgical interventions due to our recent success with similar symptoms to past pitchers. Athlete was told that 68 weeks of rehabilitation would be necessary before returning to game activities, therefore placing him on the 15-day disabled list. I will attempt to clarify and define this case using the International Classification of Functioning, or known as ICF, disablement model to better assist in this case. The ICF model provides a dynamic model of the interactions of impairments, functional limitations, and role participation. You will see this ICF model pertaining to this case in my figure 1 in my Word document. Using that model, the health condition is the latissimus strain. The body function and structure indicates the 8 out of 10 Penn scale, decreased range of motion, 3+ manual muscle testing, decreased strains, and the MRI findings showed inflammation of the left shoulder. Under the activity, shows more of the plyo program, increased strengthening exercises, the interval throwing progression once he's being cleared by a physician to begin the throwing program. In the participation module, there it shows something that could be performance-based. There includes the progression of his bullpens, progression to limited game activities, including his innings pitched, pitch count. The environmental factors there are included is where would the athlete be doing his rehabilitation, whether it be under a club supervision or in our Arizona facility with our rehabilitating coordinator. This will also include who's doing his rehab. Is it our staff members with the team, or will this be more of a formal physical therapy back in his hometown? Personal factors included here is this being the first time he's being injured, first time on the major league disabled list, a separation from his teammates, and possibly away from his family members if having to do this in Arizona. An area that we at the professional level rarely mention is the athlete's health-related quality of life when dealing with an injured athlete throughout the rehabilitation process. Majority of the time, we are more focused on the clinical-based approach than the patient-based outcome because of the business side of the profession. By definition, though, the health-related quality of life is a broad, multidimensional concept that refers to a synthesis of several health domains, including the physical, psychological, and social domains of which are affected by individual experiences, expectations, beliefs, and perceptions. It's fair to say that this athlete going through this injury the first time at the major league level and at 26 years old and competing at the major league level could affect his health-related quality of life. Therefore, we try to manage his care through the ICF model that could affect his health-related quality of life. More specifically, as we take this athlete away from his surroundings and work him up back to play, could obviously affect a lot of moving parts. When selecting a specific patient-rated outcome instruments, they have to relate to the specific disease, injury, and population or anatomical region that we're trying to target. Here in this case study, I thought about using just two two that pertain to the specific case. One is the Kern-Jobe Orthopedic Clinical Scale, also known as KJOC, and the Penn Shoulder Score Scale, known as the PSS questionnaire, that I believe both of them are pertaining to this specific case. The KJOC is a shoulder and elbow questionnaire that has been shown by previous studies to be more sensitive than other validated subjective measurement tools in the direction of upper extremity dysfunction in overhead throwing athletes, whereas the Penn Shoulder Score Scale is a more reliable and valid measure for reporting outcomes of patients with various shoulder disorders. Once I did a little more research regarding those two in the literature, and after reviewing those two, I would have preferred using the Penn Shoulder Score Scale over the KJOC, I think largely because the article pertained to the validity and reliability of this test. I originally thought that the KJOC was going to be more preferred instrument, but I found it to be interesting after looking at the other literature review that the KJOC determined shoulder injuries in overhead athletes in this particular article wasn't as validity or reliable as I had thought. The PSS indicated the use of shoulder outcome measures to assess the patient's self-reports levels of pain, satisfaction, and function, which would be more appropriate in my client case scenario. Plus, most patients completed the scale in less than 10 minutes, and the clinician can typically evaluate the final outcome in less than 2 minutes, which I thought was could have been critical in applying in this athletic population. So what does this mean in my case scenario? I use the Penn Shoulder Score Scale. It's the Likert questionnaire to address my patient's current health status and his health-related quality of life that would need to be determined to see if there was any clinical, what we found to be would clinically make him better. Using the PSS instrument scale, which I have attached into the my report as well, I did it as a pre-test as well as a post-test. In my patient score, I did the actual scoring, and my first time doing it, if I was the athlete with the provided symptoms, my total score was 41 of 100, and I did it about 3 days later. What I would have presumed that the athlete would show some improvement, and I did the score again, scoring a 52 out of 100. That was 3 days after care, and I'm using the same literature that I used the PES scoring scale based on the statistic provided in that same article. The SEM was plus or minus 8.5 scale points based on a 90% CI. The MDC at the 90% confident level was at 12.1 scale points. Based on my comparison, we can reasonably confidently say that the patient has demonstrated true improvement because of the change of 13 points is greater than the MCA value of 12.1 scale based on the literature review of that article. I believe that if we started implementing a PRO instrument collection in my clinical setting at the professional level, certain specific strategies would have to be implemented. First, it would make sure that the entire staff was on board with the process and becomes efficient in the patient-related outcome assessments. We wouldn't have half the staff be familiar with the process and the other half not. It would just not use the total staff involved. Second, we would target around the patient-centered approach as opposed to the clinical-based approach if we wanted these instruments to be productive. I believe since my clinical setting is very specific to just one type of athletic population, and most of our musculoskeletal injuries come from upper extremities and overuse type injuries, our type of patient-related outcomes would have to be region-specific scales to begin with first. I have mentioned that the timing of this instrument in my article here would be that we do this in the spring training and then do it at enough time to calculate during the All-Star break and then at the end of the season. That way that it would provide enough time for us to calculate, make changes, and alter the player's off-season care approach prior to the player departing the city that we're working in. I believe that starting small and having success with one instrument at a time would go a long way to better address change in how we would implement care to our athletes while addressing the overall player's health-related quality of life. When we talk about barriers here, I think two barriers come to mind. First is the commitment of the players to take the time to actually do the questionnaire. So time constraint would be the first one. Even though it takes less than 10 minutes to fill the PSS scale, there are a lot of players that would not take the time to fill it out, especially since we currently use the CoachMe Plus application on the iPads that I mentioned earlier in this class, and to determine the individual's player's care status. And it takes less than 2 minutes, and yet we have about 50% participation right now using that CoachMe Plus. So having to educate the players on the pro instruments or measurements in the future, I think that the framework right now that we potentially have been using, the CoachMe Plus, would help us guide these athletes in the future to hopefully introduce them to a more specific base instrument like the PSS. Another barrier I see in the professional level is the time committed for our staff to implement the score, these measurements. Once we have player committed to using the pro measurements, the majority of our time now falls in the preventive maintenance of our 25-man roster players on the major league level. Since we play every day for a total of 162-game season, we try to implement a good routine maintenance care for each player. We have a full staff now with only 3 ATCs traveling full-time and 2 additional staff at home. And to maintain appropriate care for our 25-man roster, taking a staff away to evaluate these outcome measurements could be a little overwhelming. So hiring of additional staff would probably be beneficial. Maybe hire a fellowship program or outreach clinic to assist in providing this care would probably be ideal in the surroundings. But other than that, I think with the amount of staff that we have would be limited or a barrier in this providing some PRO measurement outcomes in this professional setting. But other than that, though, I think that both are doable and potentially make a difference in our professional athletes using this patient-rated outcome measurement in this clinical setting. I hope you enjoyed the video, and I'll talk to you all soon. Thanks. Goodbye.